Hello everyone, and welcome to another episode of Let's Talk Hereditary. Dr. Church, thank you for being with us today. What we wanted to talk about today is patients with something called oligopolyposis. There's a couple of syndromes that can cause multiple polyps in the colon and the rectum, which is different from FAP. So do you mind explaining that for us a little bit?
Certainly. Well, oligo is a prefix that means a few, or not many, but more than one. And in terms of counting polyps, oligopolyposis is defined as any number of polyps between 10 and 100 existing at the same time. That's the important thing, because that's where these syndromes come in. If you have a strong tendency to polyps, over years you can build up the numbers that get taken out. It doesn't really count as oligopolyposis. So if I'm doing a colonoscopy and I see 63 polyps in the colon, that patient has oligopolyposis. That's going to make me want to do genetic testing on that patient to see if there's a syndrome. And then I have to worry about controlling those polyps and the cancer risk that they represent.
Do all patients who have oligopolyposis need surgery? We see patients that come to us and they've had 20 polyps in their colon and they've been told that they need their colon out. What are your thoughts about that?
Well, our prime responsibility to these patients, as to any patient, is to stop them from getting colon cancer. That's one of the main reasons that I exist, that you exist. We want to prevent this disease. So whichever way we can do it that involves the least harm to the patient is the most appropriate way. So for me, if I see 20 polyps in a patient and they're all take-outable, I'm going to take them out through the colonoscope and avoid surgery, because I believe that's in the best interests of the patient. If Joe colonoscopist down the road sees 20 polyps and he doesn't think he can take them out, and he doesn't want to refer that patient anywhere else, he may recommend surgery, which in my mind would be a mistake. But that's just a function of going to Joe colonoscopist down the road.
So I think the main thing we want to emphasize is not everyone with 20 or 30 polyps needs surgery. If the number of polyps is something we can control, that we want to do it endoscopically. And if someone locally can't do it, we want them to see someone else to see if this is manageable or not.
Exactly right.
What are the hard indications in a patient like that that you would say you do need surgery? You have a patient with 20 polyps, but in your clinic you say, no, you do need surgery. When would you say that?
Well, if I thought one of the polyps was a cancer, and even then, if I couldn't take it out with a good expectation that that's all that would be needed. Then if I took the polyps out and they came back with what we call high-grade dysplasia, which means they're high-risk polyps, I might be a little antsy. I would be more inclined to follow them up at a short period of time, maybe 3 months. And then if I saw that there were another 20 polyps with high-grade dysplasia, that's telling me that that colon is unstable and that nobody wants to have a colonoscopy every 3 months for the rest of their life. And so the better thing to do under those circumstances is to bite the bullet and take the colon out. So I form an assessment about the stability of the colon, how likely cancer is to happen in that particular patient, and whether I can actually control the polyps technically with the snare.
So we talked about avoiding surgery in those patients. I think the most feared or thought about test or exam that everyone thinks about, even I think about, is getting a colonoscopy. So I think we should address that a little bit, since that's something we recommend to most of our patients. So what's a colonoscopy?
Well, colonoscopy is looking in the colon and inspecting it and dealing with things that need to be dealt with and can be dealt with through the colonoscope.
So if I'm a patient coming to see you in clinic and you're scheduling me for a colonoscopy, how would my journey start?
Your journey would start by finding out about it. So we like to have our patients well informed. We have videos that they can watch. We answer their questions. It depends a little bit on the reason for the colonoscopy. So if it's average or screening, then they're motivated to get the colonoscopy so they don't get colon cancer. That's the prime motivation, and that's the commonest motivation, and that's an appropriate motivation, because we can prevent colon cancer by taking out polyps. So colon cancer never needs to happen. And so having decided and being happy with the decision to get a colonoscopy, it's a matter of timing. So it depends where they live, how far away they live. We choose a prep which is the worst part of the colonoscopy. There are some newer preps that involve drinking a lot less than the original prep, which was a gallon of nasty tasting stuff. So that's almost historic, although it is the cheapest prep. And then making the appointment. Then you have to have a friend or a relative to drive you. You will probably get some sedation, although you probably won't be completely knocked out. You'll have the exam, which will take on average 20 to 25 minutes. And then you'll recover for an extra 20 to 25 minutes. And then you'll go and have a big meal.
So when you talk about colonoscopy with patients the same day they're getting their scope, do you tell them, are there any risks for getting a colonoscopy? I know overall it's a benign procedure and there's no problems associated with it, but there are certain risks for it.
Well, the risks of a diagnostic or a screening colonoscopy are very uncommon, but nothing is guaranteed, and the risks are not absolutely zero. But the gains to be made from having a colonoscopy and not getting colon cancer are great and completely outweigh concern about the risks. Once you start doing things, the risks go up. So taking out polyps is the commonest thing to do, and there is a risk of bleeding after taking out a large polyp because it may have a large artery going to it. We would never let you out of the colonoscopy unit while you were bleeding, so you won't be bleeding when you go home. So we have to stop blood thinners, you have to keep your blood pressure under good control, and the risk is about 1 to 2% of bleeding. There is a small risk of perforation, and this tends to be overestimated because people talk about it. Like they may have had a friend of a friend who had a father who got perforated, and then that's all they can think about. That happens about once every 10,000 cases, so it's very, very uncommon. And as time has passed, our colonoscopes have got kinder and better, our techniques are better. I've had 30 years of practice, so I'm a bit better. Everything is getting better.
When a patient gets a colonoscopy and someone tells them they couldn't finish the colonoscopy, they have a twisty colon, should they never ever get a colonoscopy again, or what's the solution for that?
Well, you find out pretty quickly when you're in this line of work that colonoscopy is operator dependent. So some people are very good at it, some people are okay at it, some people are not particularly good at it. And patients know this, and patients ask for ratings of colonoscopists, and you can get that. And there are a variety of quality indicators that you can look at. Your family doctor should know who's a good colonoscopist in that city and who he would rather not send his relatives to. And so if you get somebody that's really good and they can't do it, the odds are that nobody can do it. If you get colonoscoped by somebody who's maybe Mr. Average, then maybe somebody who's Mr. Very Good will be able to step up and finish it.
Okay, so I'm not going to pretend like I'm inside the colon, but you're putting a colonoscopy and you're looking at the screen. So if you're walking us from the beginning to the end, what are the parts of the colon that you go through, and when do you know you're at the end of the colon?
So the colonoscope enters through the anus, which is not a very comfortable thing to have happen. It shouldn't be painful. It just feels bad. I've had 4 colonoscopies myself, so I know from where I'm coming. And then immediately you're in the rectum, which is about 8 inches long and straight. Then there's a bend, and that bend can be very tight or not very tight, and you enter the sigmoid colon, which is the reservoir for stool. That's about 2.5 feet long and quite twisty, and the slimmer you are and the more woman you are, the more twisty that can be. So there are techniques to get through there comfortably. And then you enter the descending colon, which moves up towards the left upper abdomen, where the colon does a turn and goes right across the upper abdomen, and then turns again and goes down to the right lower part of the abdomen, which is where the appendix is. That's the beginning of the colon, so the end of the colonoscopy. That's where the small bowel joins the colon.
So that's your finish line for part 1 of the colonoscopy.
That's right.
So now you're going back. So now that's your main screening. How do you screen the colon? And when you start seeing polyps, what do you do with them?
So the aim of doing colonoscopy is the colon is about 6 to 7 feet long. We aim to examine that with about 2.5 feet of scope. So the way we do that is to bunch up the colon like you'd bunch up a stocking when you pull it on your foot. And so then the colon is straight, the exam is comfortable, and most importantly, the inspection is more accurate. So the most important part of the colonoscopy to me is the inspection. It doesn't matter if you're an expert at inserting the colonoscope, you do a bad job pulling it out and checking to find polyps, because that's the reason that you're there. So we make sure the preparation is good. We have an irrigating system where we can clean off bits of stool if we need to and get a good look. And then our aim is to inspect the entire lining, 100% of the lining of the colon. And the colon has nooks and crannies. It has little twists and turns and kinks. So we have techniques for making sure we get a good look. That may involve moving the patient on their side, to the other side, on their tummy, on their back, just to make sure the colon is fully inspected. And as we pull out, we try and decompress the colon. And as we pull out, if we see anything of interest, we'll note it. And if it's a polyp, then we'll take it out.
When you're scoping patients with FAP, and those patients have a lot of polyps in their colon and in their rectum sometimes, how do you look at those polyps, and which polyps do you decide you need to take out versus not?
Well, in FAP, the situation is you see the polyps on the way in, of course, and you get an immediate impression, are any of these polyps bad polyps? Are they malignant polyps? Could they be malignant polyps? And that relates to the size and appearance of the polyps. So we make note of that, because if the patient's going to need surgery after our colonoscopy, we don't really need to take any of them out. If our impression as we do the colonoscopy is that this patient doesn't need immediate surgery, or let's say they have oligopolyposis, less than 100 polyps on our gestalt, our impression of what we see, then we're going to start counting them. And in addition, we'll start taking out polyps greater than 5 millimeters, because the odds of there being a cancer or something undesirable in a polyp 5 millimeters or less are very, 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 very low. And I'm happy to leave polyps 5 millimeters or less and take out any that are bigger. And then as we come out segment by segment, we do as accurate a count as we can and to make a note of it, because when you're checking patients with FAP and not operating on them, one of the important things to know is how is the disease changing with time. So if I take out 60 polyps this year and I count another 40, next year I want to see what's happened to the counts. Are the polyps getting more numerous rapidly or just a little bit? Are they getting a lot bigger? Is the risk going up? Is it time for surgery next year? If things are stable, then perhaps we can put it off another year, etc. So that's the basic technique.
My last question for today, does taking polyps out hurt?
No.
Okay, I'm glad.
There are no sensory nerves to the lining of the colon, so you can do what you want with it.
Okay, I'm glad. Well, thank you for being with us today. Thank you everyone for listening. And if you have any questions or concerns, find us on social media or call us at the Y Center, and we'll be more than happy to address your concerns.